Thank you for that introduction. I feel very privileged to be delivering to you the fifth Dr. Elena Ines Cuyegkeng Memorial Lecture at this conference. As you probably know, I am not a medical educator, so I do not have the expertise that is gathered in this virtual room. However, as your fellow educator, I am hoping that through the ideas that I will share with you during this talk, during this lecture, you will be provoked into thinking and talking about the future of medical education in the country. The title of my talk is Imagining the New Possible in Medical Education, and the subtitle is Some Conversation Pieces, an appropriate subtitle for what we hope to do during this talk. None of us expected it, but during the pandemic, because of the disruption caused by the coronavirus, suddenly we found ourselves, educators, whatever our discipline, thrust into a global teaching experiment. Because that's really been what's happening the past 2 years. I don't know about medical educators in particular, but certainly educators that we have talked to, educators that we have trained during the pandemic, we felt that we had to explore different ways of delivering our learning and teaching in lieu of face-to-face classes. And it was really a very unique experience because none of us was prepared for this global teaching experiment. No? As learning and teaching went online, we educators were put on the line. There was a lot of pressure on us from our different stakeholders, including our students and, of course, the parents of our students, that we had to level up, that we had to upskill, that we had to make sure very quickly to learn new skills, new capacities in order to continue to promote learning among our students despite the disruption. And it wasn't easy for us. No? Many of us really had difficulty. We had difficulty adjusting to the online learning environment. It wasn't easy for us to learn almost overnight all the educational technologies needed that we needed, no? to be able to shift to online remote learning. No? And just as many of us were getting used to it, we continue to wrestle with some of these issues. No? For example, is online learning effective? No? What are the benefits of online learning and what are the trade-offs? What are the things that are lost? No? Because we are not face-to-face, but because we have gone online. I think these conversations continue, no, as we navigate how we will shift back to face, no. But I think what's important here is the mindset that's captured in the phrase for crisis in Chinese, no. In Chinese, the word for crisis is weiqi, which is really two characters that stand for two different things, no. The first character, wei, usually used in conjunction with xian, wei xian, means danger. And qi is qi hui, which means opportunity. The Chinese wisdom, therefore, tells us that even if we went through a crisis, no, and there was danger and risks in this crisis, there were also a lot of opportunities. So given all the things that we have learned, how can we imagine, no? How can we imagine the new possible in medical education? Let me just say a little bit about the title, no? Because a lot of thought went into the title. No? Usually people would say, imagining the new normal in education, or in this case, in medical education. But I made a deliberate decision not to use the new normal, but to use the phrase, the new possible. And what's the reason? The new normal is basically what we talk about when we're talking about the new scenario, the post-pandemic scenario. What is it going to be like? When we come back face to face? Is it going to be similar to the pre-pandemic situation, or is it going to be a little bit different or very different? No? The problem with using the phrase new normal is that we don't know what the new normal is. No? So I prefer to use the phrase the new possible. No? Because when you think about it, what do we do with the new normal? We merely need to adjust to the new normal. And it's not something that's easy to do because we don't know what the new normal is going to be like. What about the new possible? Well, we educators actually have the capacity to define the new possible, given all the things that we have learned during the pandemic, all the struggles, all the difficulties that we experienced, no, during the global teaching experiment that we all had to go through. how can we define the future of education? How can we define the new possible of education, especially in your field, in the medical field? No? So the question I'd like to ask, or the invitation to us really is, let's define the new possible rather than simply adjust to a new normal that we have no idea about. No? So the question I'd like to ask really is, what proactive strategic choices can we educators make about the education we offer based on what we've learned these last few years during the pandemic? So that's a question I hope that we will begin to think about as far as medical education is concerned. So to segue into the new possible in medical education, as I said, I am not an expert, but I am a rather eager and curious observant of education in different fields. No? Very recently, while attending a conference, I met a person who introduced herself as a narrative designer. I've never heard of such a profession, a narrative designer. No? So in the course of conversation, I learned what her job was all about. And it's really very interesting because this is an example of a profession that has been bred by technology. No? Years ago, we would not have imagined such a profession was possible. But because of digital technology, these types of profession have really mushroomed. No? And what's a narrative designer? A narrative designer's job is to design the narrative elements of a game based on how players interact with its story. You know? So it's really about games. No? When you think about it, a narrative designer is somebody who not just writes out the script of the game, but focuses on the characters in the story of the game. That's very interesting. What's even more interesting is that the narrative designer that I met wasn't involved in a game. No? She was employed by a company called Shadow Health. No? And this company, Shadow Health, is really engaged in doing something that's related to medical education. So I'd like to show you a very short clip of what Shadow Health is all about. It's about 2 minutes long, so let's watch it and let's see what we learn from this short clip.
Best in-class simulation experience leader in healthcare education. Virtual patients have diverse personal and medical histories and can answer hundreds of thousands of questions, so the responses are as varied as the patients themselves. Conversations in real life aren't scripted or multiple choice, so Shadow Health's digital clinical experience creates real-life situations for students to apply clinical judgment when addressing each patient's individual needs. It's from these virtual patient interactions that instructors can truly quantify students' critical reasoning skills, and the instructors' detailed assessments are what differentiate Shadow Health's simulation experience from any other. Let's step into the exam room. It's an hour after the student's initial patient assessment. Now we can watch the student's interactions with the patient, Gabriel, and his mother, Yvonne.
I feel better now. I can definitely breathe better, but my chest is kind of sore.
An important part of the learning process is for students to be able to balance asking questions, delivering therapeutic communication, and educating the patient. Simulation experience encourages students to practice clinical reasoning skills through realistic interactions. Now let's check on soon-to-be mom, Luna.
I'm excited. After today, there's gonna be a new member of our family.
More than asking patients questions, the simulation experience includes opportunities for nursing interventions and for demonstrating empathy toward patients. Thanks to Shadow Health's simulation experience, when students complete their healthcare studies, they're patient-ready, capable, and confident.
So what did you think of what you saw? What did you think of this software? I'd like to give you a couple of minutes to just perhaps type in the chat box some of your reactions. No? And since I'm not going to be there live with you, I'd like to invite you to read the comments of the other delegates in the conference and feel free to respond. No? So let's have a little digital discussion. Okay, so I hope you had a little virtual discussion amongst yourselves, and I'm going to guess that there's a variety of reactions, no? Some of you may have been excited by the prospect of using such a digital software to conduct medical education. Others might have freaked out, maybe, or found it a little too strange, no? But what's really interesting about Shadow Health is that it gives you all these CGI created characters, these patients, no, and it gives the learner, the student, a chance to interact with the particular characters, the different kinds of characters. No? In this case, for example, we have a Chelsea Warren, no? And at the same time, the students in the course of their interaction are able to use their knowledge, no? And also at the same time, they're able to demonstrate to the teacher whether they mastered the medical concepts that they're supposed to master, and applying these concepts, no, in their interaction with the digital characters, no. So Shadow Health offers digital clinical experiences to enable medical and nursing students to diagnose a digital standardized patient and develop their clinical reasoning skills, no. I personally found it very, very interesting, very exciting, no? Because really, it's important for students to be able to apply what they've learned, no, from books, and this really gives you a chance to see how your students, whether they're medical or nursing students, these future health professionals, how they will actually interact with patients, no. As all of you, I'm sure, will attest, no, there's nothing like experience to show that it's not enough to just know the concepts, no. The personal interaction with the patients is also very important. So in a way, shadow health allows us to see more than just the application of clinical reasoning skills, no. If the patient is, for example, an African American or of a particular minority, then the doctors and the nurses' interactions with that patient will also have to change, for the medical and nursing practitioner to be effective, in their field, no. For example, here we have another character, Tina Jones, no, and you will see what the software Shadow Health is able to do, no. In this particular case, it says here it can improve bedside manner and increase confidence with future patients, no. So in a way, Shadow Health can also help our students become patient ready, no, because it builds their confidence. Let's watch another short clip to see exactly what is entailed, no, in Shadow Health.
Shadow Health's Digital Clinical Experience, or DCE, provides a dynamic, immersive experience designed to improve your skills and clinical reasoning through the examination of a digital standardized patient, Tina Jones. Tina is a 28-year-old woman who has come to us to receive treatment for an infected foot wound, fever, and decreased appetite. Although a digital patient, Tina Jones breathes, speaks, and has a complex medical and psychosocial history. Each assignment within the DCE represents one piece of Tina's comprehensive assessment. By breaking Tina's assessment into individual assignments, you are able to apply your knowledge and practice your skills to each system in greater depth throughout the 8-week course.
Okay, what did you think of that? Again, I will give you a couple of minutes just to react, no? Whether you think this is something that's going to work, if it's going to be helpful in your practice of teaching medical and nursing students. No? I'll give you a minute to do that. Please type it up in the chat box and feel free to respond to one another. Okay, so I don't know what your reactions have been to the software, but some of you, it's very possible that some of you may be a bit skeptical. No, you might be saying, "What's the point of having all this multimedia design and augmented reality?" Especially in a country like the Philippines, it's something that very few schools can afford, if any at all. No? The point I'd like to make actually in sharing with you this software is not to sell it to you, even if I sounded like I was selling it to you. The idea really is that it's not so much about the multimedia design or the augmented reality, but about the problem-based learning and the more inclusive learning outcomes that impressed me. No? What do I mean by that? No? Um, I think problem-based learning is really an effective way to prepare professionals, no? Especially medical and nursing professionals. Because really what a doctor does, no? And what nurses do is that they really deal with problems in the real world. What I really like about this software is that it does just that. No? It invites the learner to interact with patients, even if the patients are merely digital, no? So that they will be able to apply what they've learned. They're not just being asked to recall what they have learned in classes, but to put all of those together and to apply them, no? And to solve a problem. No? In this case, to diagnose a sickness and to offer an intervention. No? So the problem-based learning is what really struck me about shadow health. No? Secondly, it's the more inclusive learning outcomes. No? The software allows the students to demonstrate not only that they remember the medical concepts, the symptoms for a particular disease, and so on and so forth, but it includes other learning outcomes that are important when it comes to doctors and nurses. No? What are these learning outcomes? Bedside manners. How do I deal with patients, and how do I deal with different kinds of patients? No? But also, how do I deal with them ethically? No? If the patient raises certain questions that are not from the books, no? How will I deal with them so that I become an ethical medical or nursing professional? No? So for me, when it comes to the future, the new possible in medical education, I'm not here to say we must go digital. That's not the message. No? The message here is we have to make sure that our students are able to apply what they've learned, in this case, problem-based learning, no? And that we focus not only on the technical knowledge of our students, but also on what it takes, no, for a medical professional or a health professional to be effective. No? So it includes ethics. It also includes personal interaction or bedside manners. So the first big idea that I'm hoping to communicate to you during this lecture is that it's not so much about technology, but it's about the pedagogy. No? It's about how we are teaching, how we are offering medical education to our students, even if we're not doing technology. No? So my question to you is, would it be possible to think of non-digital real-world simulations? What do I mean by that? No, I'm talking about not buying software. That's probably going to cost so much, no? But coming up with simulations and using them in class. They're non-digital, but they're real-world simulations. Is it possible to offer our students case studies, no? Where they encounter problems other than the simply technical, no? There are also interpersonal issues, no? And these are also talked about and discussed in class. Or better still, can we have more of role plays, no? To promote this kind of problem-based learning, as well as the more global, the more inclusive learning outcomes. So the pedagogy is important. So perhaps I think as we're trying to reimagine the new possible, it's not about rushing to the supermarket of digital technologies and buying whatever is the latest software like Shadow Health. No? It's probably going to be very expensive. It's probably not going to be affordable for many of our schools, if any of our schools can afford it. No? But we can follow the more important pedagogical principles that underline Shadow Health. I remember my nephew took the medical board in the US, and he was telling me that a certain phase of the board exam, no, had actors dealing with the examinees, no. So the examinee would enter a kind of cubicle, and there would be an actor there who would be acting out a role of a patient. So it's not digital, but it's a real actor, and so in the course of the interaction, the focus is not only on the technical knowledge of my nephew, although that's of course important, but also they're also graded, they're also scored on the basis of their interaction with the patient and their bedside manners. No? So I thought that was very interesting. So would it be possible to think of something like this for the medical education in the Philippines post-pandemic? No? Speaking of technical knowledge, which is usually our default focus, no, Donald Sean in 1984 and 1991 came up with a couple of, for me, world-altering views, no, and ideas. No, the first one is called the Reflective Practitioner. The subtitle is How Professionals Think in Action, no? And the second is Educating the Reflective Practitioner. No, the subtitle, which is not shown in the book, is Toward a New Design for Teaching and Learning in the Professions. When I was invited to give this memorial lecture, I immediately thought about Donald Sean, because I remember when I was doing my doctoral studies, these were the two books that really blew my mind. No? And they're really about professional education. There are two very important big ideas here which I'd like to share with you. No? And if you get a chance, you may want to read the book. But the first big idea is about what a profession is. No? How do we define professions today? No? And basically, Donald Sean builds on the Nobel Prize winner Herbert Simon's definition of a profession. No? The professions, according to the book, including the medical profession, are the so-called artificial sciences. That's actually a phrase from Herbert Simon. No? It's an artificial science because unlike the natural sciences, they entail design. No? So if you're a professional, it's all about making designs. No? So it's very interesting. Let me explain it a little bit to you. Let me elaborate on that. No? The first two professions that come to mind when we talk about design are architecture and engineering, because both explicitly entail design. No? An architect is given a space, no, to work with, and an architect is given the preferences of the client, and given these constraints, no, the architect is supposed to come up with a physical entity, no, an artificial, an artifact, an artificial thing. No, it's not natural. No, should design this based on that. The engineering is the same. No, the engineering has to come up with something artificial, something physical, no, to be able to solve a problem also. Okay. But what about the medical doctor and the educator? In what way are they artificial scientists? No, some of you may say, I'm not an artificial scientist, I'm a real scientist. No, but basically what it means is that medical doctors and educators are also involved in the profession of design. No, our main job really is also to design. Think about it. No, a medical doctor meets a patient, and the patient has her complaints. No, her symptoms, and so on and so forth. No? And what the medical doctor has to do is really, given the information shared with him or her from the patient, the medical doctor is supposed to design an intervention to treat the illness. No? In the same way, an educator faced with students, no, should try to understand the context of the students, and given the goals of the course, no, the educator is supposed to design the learning environment as well as the learning intervention so that the students will learn something in class. No? So any profession really entails design, and the output of the profession need not be physical like the architects and the engineers. No, for the medical doctor, it's the diagnosis and the treatment. That's what the medical doctor is designing. The educator is designing the class, no, the syllabus as well as the lectures and so on and so forth. No, now that's the first big idea. The second big idea is that Sean makes a distinction between a profession thought of as a technical expert and a profession thought of as what he calls a reflective practitioner. Let me go through each one. No? A technical expert possesses all the technical knowledge necessary to solve problems. So for example, a medical doctor An effective medical doctor should have all the technical knowledge necessary to solve problems. No? And it makes a very implicit claim, no, that problems are self-evident and there is one correct, verifiable solution to each problem. No? So that would be the technical expert. According to Sean, this particular conception of a professional is already passé. We should not think of a medical doctor, for example, no, as a technical expert. Technical expertise is important, but more important than technical expertise is what he calls reflective practice. No? And what is reflective practice? No? Compared to a technical expert, a reflective practitioner uses the trial and error method to solve problems and revises initial solutions based on the results. So for example, a medical doctor may listen to the symptoms of a patient, no? And given what he has learned from the patients, he may try a particular treatment. No? He may have a particular treatment but the patient may come back, no? And based on the results of the treatment, the doctor is expected to revise the prescription, revise the treatment that he is offering. No? What's important about the reflective practitioner, as many of you experienced medical professionals know, no, is that this is more accurate as far as our practice is concerned. No? It is not true, although we wish it were so. It's only in very few cases that problems are self-evident, no? As the technical expert model assumes. No? For the reflective practitioner, there's an acknowledgement of what is called the indeterminate zones of practice. In short, the area where we practice, the field where we deal with patients, no, and we try to come up with diagnosis and treatments, no, it's indeterminate. No, it's not very clear. It's not self-evident. No, and more importantly, precisely because it's not self-evident, no, it's not just about problem solving, as the technical experts will say. No, for reflective practitioners, more fundamental, no, and more crucial is problem setting. No, we have to define the problem first, and you medical doctors, of course, are very familiar with this because you have to come up with the diagnosis first before the treatment. No, but the diagnosis is not self-evident. It's important to define the problem, and sometimes you have to revise the definition of the problem for you to come up with a solution to that problem. No? So what's interesting here, I think, is that if you're a novice in your field, you might be naive and you might think that technical expertise is all you need. But the more experienced you are, I think the veterans among us in this room, no, the medical doctors and educators will say that the reflective practitioner is a more accurate model, because certainly technical expertise is important, but much more is needed. No? So when we think about the software shadow health, no, the more inclusive learning outcomes are also included. You have to know how to deal with patients, to interact with them, but also you have to know how to revise your prescriptions, no, and your diagnosis. No? So really, medical doctors and educators are not so much technical experts, but should be more reflective practitioners. So the question I'd like to ask here is, what kind of health professionals are we producing in our schools? No? Are we producing only technical experts who can memorize all the symptoms for all the different illnesses and so on and so forth? Or are we actually preparing them to face their patients, because we're producing reflective practitioners? No? These are medical professionals who are not only technical experts, but they are willing to listen to patients, no, and dialogue with patients to learn more about the condition of the patient, so that a better, more accurate diagnosis and treatment can be offered to the patient. No? The last idea I'd like to share with you is that it's about assessment. No? So I was talking about pedagogy, that the pedagogy should be problem-based learning, so that our students can learn how to apply what they've learned. No? And that it should include other learning outcomes aside from technical expertise. No? In short, we should prepare them, our pedagogy should prepare them to become reflective practitioners. No? The third idea, the third piece, I think, and I think the most important piece, is that More than pedagogy, assessments are important, are crucial. So remember earlier I said more than the technology, the pedagogy is important. But now I'm saying that more than the pedagogy, the assessments are important. There's a saying in education that if we treasure it, we should measure it. No? So if we treasure the more inclusive learning outcomes, we should also measure it. No? We should not only measure technical expertise, but also the capability of our students to interact with patients, no? To dialogue with them, to listen to patients, to understand the situation of patients better, so that they can improve their diagnosis and the intervention that they're designing. No? Now, assessment is such an important piece. We saw this during the pandemic. No? Many medical educators were quite concerned about academic integrity, no? Because obviously in online learning, it's very difficult to control the students, no? And some schools who could afford it resorted to softwares that could monitor the students better when they're taking exams. Although even if these softwares are expensive, they're never foolproof, no? But I think it's important for us to think about assessments for a while, because if we're very concerned about academic integrity, no, about rampant cheating in the online learning environment, it really tells us what you are measuring, what you are assessing. No? Because it's easier to cheat when you are only measuring technical expertise. But if you're measuring things that are more than that, application of technical expertise, no, it'll be more difficult to cheat actually. No? So I think for us to reimagine the new possible in medical education in the country, we also have to think about our assessments, no? Especially the high stakes assessments, especially the board exams. No? I don't know how much influence or authority this body will have in terms of defining the board exams, but if the board exams, no, are all about technical expertise, are limited to technical expertise, then that's what our students are going to focus on. But if we begin to include the more global competences, no, that are actually needed in the profession when we're dealing with patients, no, like bedside manners, interaction with diverse patients in an effective way, no, but also listening to patients, no, becoming reflective practitioners. If we can include that somehow in our assessments, especially our high-stakes assessments, then I think we will have been able to define a better possible for medical education. No? So in summary, I'd like to say that as we are imagining the new possible in medical education, it's not really so much about technology for digital learning experiences. That's not the new possible that I hope you will aim for. Better than technology is the pedagogy, a pedagogy that includes more inclusive learning outcomes. But really what will really be crucial will be assessments of real-world competences expected of the professional practitioner. So the question is, a medical doctor today, a health professional today, what are the global competences expected of a health professional? It's not just technical expertise. No? It's also bedside manners, but it's also especially being a reflective practitioner, being able to listen to the patients and dialogue with the patients to better understand the patient's condition, no? Especially when the patient is unable to express, no, or articulate, no, his or her condition well, no, to be able to handhold the patient in expressing, in describing his or her condition, no, and to be able to assess that, especially in our high stakes assessments like the board exams. No? So that's about it as far as my lecture is concerned. I hope this has been a provocation to you. No? I hope I've been able to offer you some conversation pieces to think about how you would define the new possible in medical education. I hope you will not get stuck about technology, but you will think about the pedagogy and especially the assessments, no, that will be called for by the new possible. Thank you very much for your attention and your patience. I hope this has been worth your while. Thank you very much.